I got this other thing, so now I'm getting my benefits. You know? But it was like so cute when he did it. You know, like that's the kind of guy. You know, it's super.
How you
Hey,
doing?
there's the boss.
How are you?
Good, sir.
Good to see you.
Our speaker.
How y'all doing? I'm Ned.
Fernando.
Nice to meet you. I'm Ned. Nice to meet you.
Nice to meet you, Ned.
Alright, so
We got 8 minutes. Oh. Yeah, I just sent you an email in case you didn't know you were live.
Yeah, we were messing with some of the.
That's totally fine. Just the message came up on my tablet saying, "Hey, we're live streaming."
Yeah, wait a minute. I'm not there yet.
But it probably only sends that to the people who are subscribed.
Yeah.
You know.
So you sent out the invitation and.
Yeah, they actually got postcards usually.
Nice.
Of this month. We sent this some kind of late, but yeah, this is very good. She sent out postcards
Nice.
for those who accept snail mail.
Yeah.
And I never duck low enough. They always see the back of my helicopter landing port. Figure going through. Always in the camera, thank you.
How's the wife and kids?
Good, thank you.
Good.
Yep, doing okay.
For you.
Yeah, when I was left San Diego to go to Houston, I got to El Paso.
Yeah.
I thought, man, I'm really making progress. Shoot,
No, from El Paso to another what?
It's about almost
8 hours?
halfway.
Yeah, that wasn't even close. And I stopped for like 42 minutes. You know, I'm celebrating. Hey, I'm here. I got a sandwich.
Yeah.
Stretch my legs. Oh, shoot.
No, yeah, it's a
Yeah.
long.
Windows is up on the. Yeah, I think he's figuring it. You're all mic'd and everything, right? Yeah.
Yeah, I just need to turn it on.
Yeah. Okay.
Okay, looks like we're working on it.
So feel free to plug, you know, your, however you want to do that.
Yeah. I'll let them know how we met.
Well, leave out the drinking, but yeah. What was her name, Bambi? Or? You know, my wife watches this.
Yeah. So anyway, so we were in church one day.
Yeah, there you go. Don't I know you? Oh, that's great. But I think the Texas story, you know, if you want to share that, ALS, whatever you want to say, it's totally your pitch.
Just gonna kind of add to the lot. So.
Yeah. But what we're after for this part is a section of video that becomes part of our reference library.
Okay, good.
That's
perfect.
Here's the man. Here's what he said. You know.
I'm really just going over the importance of using it, and if you don't use it, the consequences of
There you go.
not using it.
Right.
So
Guido, you know, we're connected with the mafia. We will come after you.
we will come after you.
You know.
That's right.
Just simple.
Yeah, very straightforward.
you have the handheld mic already?
Yes. Oh, perfect.
Mic check. You usually keep this on or off?
Off.
Off. Cool.
And we're live?
Yep.
So
So
let's
yeah,
start.
we're ready to go just whenever. Give it 1 more minute.
Should see this pop out in the background here.
So good morning. Sorry we're starting a little late. We've got a little mix-up on the link that was on your email. That one we used at about 9 o'clock this morning for 6 minutes. So it's gone. So Greater San Diego ALS at YouTube. If you subscribe, you can find today's webcast and watch it live. Other than that, we'll certainly record it and have it available later. So again, good morning. Thank you for joining the ALS Association Greater San Diego Chapter Care Services meeting. And we're excited today to have a presentation on ALS and breathing, why you should use your respiratory equipment. So I'm going to let our speaker, Fernando Ortiz, introduce himself and make the presentation.
Thank you, Keith. I'm Fernando Ortiz, and I work with Respiratory Quality Services, and I'm new to San Diego. We'll be going over ALS and breathing and why you should use your respiratory equipment and the consequences of not using your respiratory equipment. ALS clinics are huge. We've been a part of the ALS clinics for 6-7 years now, specializing in nothing but ALS patients. But interesting facts here are that multidisciplinary clinics have been proven to extend patient survival rate by up to 30%, just for participating in ALS clinics. That's no medications, that's just giving patients support when they need it, and giving them equipment and needed supplies that they need, and getting it to them in a rather rapid sense as well. And basically what we're doing here is we're providing patients with a better quality of life. Since there is no cure for ALS, much of what we do as clinicians is, and support teams is we prolong life by giving patients a better quality of life. With proper management, patients can live a better quality of life and maybe even knock out a few bucket list items. Our background, we are a respiratory DME company. We specialize in patients with ALS, patients with neuromuscular disease. It's kind of a niche. We've started this about 6-7 years ago out in Texas. We probably on service right now for ALS patients. We probably service about 600 patients with ALS. That seems to be our forte, and that's what we're going to continue on with. We're new to California. We're actually brand new to California, probably less than a week that we've been here in California. Thank you, Keith. It all started probably about 8 months ago. We were at a conference presenting, and I had just presented, and that evening I was having dinner. I'll say dinner. And a gentleman sat next to me, and I started talking to him, and we had a lot in common. We started talking about fishing. We started talking about steaks, and we started talking about all this great stuff. And so then I introduced myself, and he introduced himself as Keith Miller. And so 8 months later, I find myself here in San Diego, hopefully trying to make a big impact on patients with ALS. Respiratory therapy. So managing the respiratory components of a respiratory, or for an ALS patient, I should say, it's pretty complex. When we went to school, we were taught the use it or use it mentality. We're taught in respiratory school to get these patients off of the ventilator as quickly as we possibly can. Take the support away from them and let them do the work so that they can regrow their diaphragm, intercostal muscles, so that everything comes back. Well, obviously with this disease, this is not the way that this disease works. If anything, what we're doing is we're adding support to the patient on a monthly basis sometimes. Early adaptation of non-invasive ventilation has shown to prolong survival rates in patients with ALS if they are compliant with this equipment.
Just to make it easier?
Right. So when you think about this disease, it is a muscle disease. So when we wear out any muscle in the body, we lose it, we don't get it back. Our diaphragm is what we use to breathe. Our intercostal muscles are what we use to breathe. So the quicker you wear those out, the quicker the disease process is going to go, the quicker you stop breathing. So what we've basically done is we try to take all the support away from the patient and let the machines do 70, 80, 90% of the work. The patient do 10% of the work, and therefore it preserves the diaphragm, preserves the intercostal muscles, and everything just lasts so much longer. also the prevention of pneumonia and all that, and we'll kind of go into that as well.
Doesn't it deteriorate if it's not used?
Well, so there's two things. There's what's called muscle atrophy, and then there is also what's called also the disease process taking over. We don't paralyze the muscles in any which way, so it's not going to do what you're saying about the atrophy, because you are actually still triggering the ventilator to do the breathing or help out and assist with the breathing as well. Okay. So muscle preservation. If you look at the little diagram on there, we use intercostal muscles and we use our diaphragm to breathe, and that kind of gives you a little example of what that looks like. Our goal is to preserve the muscles with the ALS patients to prevent them from catching pneumonia, atelectasis, and going into respiratory failure. So a lot of us have Googled ALS, and we have Googled what happens towards end stages, and it all leads to respiratory compromise and respiratory failure. If we can prevent that from happening, then at least in the interim for a longer period of time, it's better quality of life for the patient. You're able to do so much more. Go ahead.
What is allostasis?
Allostasis.
Is that
Atelectasis. Atelectasis is where the bases of the lungs start to collapse, and then so we call it atelectasis. It's more of a respiratory term, but basically the bases of the lungs are starting to collapse. That comes from a patient not sucking in a deep enough breath. So it's very difficult for them to suck in a deep enough breath. So what happens is the bases of the lungs start to collapse, and then the patient starts to breathe really shallow. And the patient has shallow breathing, the lungs are going to continue to collapse. You all of a sudden go and you check the patient's O2 sats like they would in a hospital, and the saturation of oxygen is low. And the saturation of oxygen is low because probably half of the lungs are collapsed and you're only using the top portions of your lungs. A natural occurrence for anyone in a hospital, a physician, respiratory therapist, nurses in the hospital, is to give the patient oxygen when they come in. The very first thing that's going to happen is the oxygen is going to come up. And they're going to say, I fixed it. Well, yeah, you just gave a bunch of oxygen to this small concentration of lungs that you are using, but you didn't really resolve the problem. The problem is get the lungs open. And that's where the respiratory equipment comes in, because we need to get the lungs open. So we'll go a little more into that in just a bit. But we also work to increase peak cough lows and to try to help remove secretions. So does ALS truly affect the lungs? It really should not. This really is not a lung disease, it's a muscle disease. Okay, so we're talking about intercostal muscles and we're talking about diaphragm muscles. So we're talking about muscles that affect the respiratory component, but truly you should not have a lung component with this, unless you told me you're a previous smoker, you've had radiation therapy, pneumonectomies, esophagectomy, anything that could affect the lungs, then yes, you would probably have an underlying condition like COPD, would require oxygen, stuff like that. But in terms of the lungs being affected, they should not be affected. So you have good, healthy lungs. Now we just need to keep them healthy, keep them expanded, keep them free of secretions. And if we do all of that, then everything just lasts so much longer. So the effects of respiratory muscles on the lungs. So there's a little bit about what we just talked about right now, decreased tidal volumes. Because you don't have that muscle strength to suck in that deep enough breath, your bases of your lungs are going to start to collapse. And that's what that little diagram shows you, a collapsed lung. Atelectasis, where the bases of your lungs start to collapse. And this will lead to pneumonia and respiratory failure. So if the bases of your lungs start to collapse, fill up with secretions, and then I ask you to cough it out, most ALS patients, their cough is very, very, very weak. So most of their coughs go, and that's it. So this is why we need cough assist machines to help bring up secretions, if there are any secretions. But take a wild guess at what can prevent atelectasis or a collapsed lung from happening. It's going to be your respiratory equipment and utilizing them and using them and not waiting until you have those increased secretions and collapsed lungs to start using the equipment. We can just try to prevent that from ever happening. We don't have to go down that road. So this is a little example of what a normal X-ray looks like. You see all the black part of it on both sides of the lungs. You see a normal trachea right down the middle, and you can actually see the diaphragm, which is right at the bases of the lungs, and you can actually see the claustrophrenic angles right on the very corners. So very nice, clear lungs. This patient takes really good deep breaths, has no issues. Okay. This is a picture of what pneumonia on an x-ray would look like. And you can see where all the black part is kind of whited out. You can see at the very tops of the lungs, you can see some air movement with the black. You can see a trachea shift where the trachea is actually shifting to one side because you probably have a collapsed lung on one side and it starts to shift the trachea over to the other side. I can no longer see the claustrophrenic angles. I can no longer see diaphragm. I can't see anything on this x-ray. So this is what a typical patient would look like by taking those really shallow breaths and making them last for a really long time without using any equipment. And then they start to catch pneumonia, secretions, and all that starts to build up, and this is what an x-ray would look like. A compliant patient. We're going to go back to that first x-ray that we first looked at. A compliant patient that uses their respiratory equipment, uses their cough assist machine, uses everything the way they're supposed to do, would have lungs that look just like this. And this can and will likely keep you from having a hospital admission. Right now on service with our company, I would say we have probably about 600 patients with ALS right now. I can go down the list and tell you which patients will admit for pneumonia and respiratory failure just by looking at the list. And all I'm looking at is which patient's compliant and which patient's not. My compliant patients, I typically don't have these issues. If they do admit to the hospital, it's for other underlying conditions. Heart attacks, strokes, we're still prone to all of that other stuff, but we can truly prevent all of this from kind of happening if you truly use your equipment the way you should be using it.
Is that because you can track what they're using? So
Right.
that
Correct.
Information is
Correct.
transferred
So
back
we
to you.
check on the
Okay.
patients every month, and by doing it on a monthly basis, we get to track the advancement of the disease. If we can stay one step ahead of the disease, meaning once I see that there is a change in compliance in the patient, then there needs to be a change in the ventilator settings and the cough assist settings. If I'm not one step ahead of it on that aspect of it, then things just get worse and worse, and the patient starts to do more of the work, and the machine does less of the work. So we need to stay one step ahead of it. But yes, we do check it on a monthly basis for that reason. Go ahead, Keith.
So before we go too much further, there's two issues that people like to talk about. Maybe it's good to get them out of the way right now.
Sure.
I don't want a machine breathing for me.
Correct.
That's been my choice.
Mhm.
This equipment is what? Is it therapy or is it breathing for me?
So a little bit of both. Okay, and I do understand what you're saying when you say I don't want a piece of equipment breathing for me. A lot of times when patients say that, and even the general public makes any kind of reference to that, they're usually talking about tracheostomies and a machine breathing for them. At the point that a patient needs a tracheostomy, it's the point where you have lost complete diaphragm function, 100% of it. Therefore, you do need a machine to completely breathe for you. Non-invasive ventilation is not going to work anymore, and you will require tracheostomy. Now, 95% of patients with ALS elect not to do tracheostomies. That's just what the numbers show right now.
95?
It's about 95% of patients do that. Out of the 600 patients that I have on service with us in Texas, I probably have 15 patients that have tracheostomies right now. And that always varies. It goes up, it goes down. But most patients elect not to.
Does sometimes, because that's kind of, we've kind of been at that point just recently, trying to figure out whether that was the right protocol to follow or not. My husband has ALS.
Okay.
So he was saying, he had a couple weeks ago where we looked like the doctors were saying, oh, you probably need a tracheostomy. So he did not want to go that route because they were trying to figure out how to clear his
Lungs.
lungs
Yeah.
with the URI. So
Right.
there was we were able to get it cleared up.
Okay.
But that was the challenge is to be able to clear the lungs when they can't.
Right. So it all goes back to making sure that the cough assist is set up properly and the ventilator settings are set up properly to make sure that, see if we are maxed out. Even with all that we do everything non-invasively. Okay? Everything is done with a little mask, a cough assist mask, or non-invasively on a ventilator. And so at some point, do we max out on the settings on both of these things and all of a sudden that just completely stops working? Yes, there is a time. But I would need to look at those settings to determine, are we anywhere near there, or do we just need to titrate a couple of different things to make this last so much longer. So it's real hard to kind of tell you exactly which route to go. But, you know, most patients, it's a quality of life thing now for these patients. And once you start talking tracheostomy, quality of life is completely different. It requires so much more help, so much more assistance. At that point, usually, limb onset has completely taken over. They have no functions of their limbs, no speech. Definitely not going to have any speech once you go to tracheostomy as well. So it's just a different quality of life. So,
Do you see a difference in patients with the bulbar ALS
yeah.
compared to?
Absolutely. So a majority of patients have limb onset, and there are probably 15-20% of them are bulbar onset.
So my husband's bulbar. That's why it's
Right,
started-
bulbar is the most difficult to treat, okay? And even when we first got into this 6 years ago, it was the most difficult patients that we could ever deal with was the bulbar patients because it completely compromises their upper airway. But what we did is we hired some researchers that started working for us and started doing studies on these patients with bulbar and as well as patients with limb onset to try to do titration of the settings to try to make the patients more comfortable with these settings and try to make the patients last longer. And so from our findings, we did find that we were doing things, not that we were doing them wrong, it's the way we were taught to do, but so much better. And so that's what we're in the process of doing. We're in the process of creating some literature for that. We're in the process of, we've already started doing all the presentations nationwide on the bulbar effect, but we are starting to, we submitted a paper already, so we're starting to publish. And once that publishing gets out, at that point the physicians and everyone can kind of jump on board with that. But bulbar patients are very difficult to treat, but they can be treated. That's the good thing, compared to a few years back.
Well, it's hard to find a patient.
Even 2 or 3 years
a
back.
physician that can treat you properly.
Absolutely, correct. Yeah, that's a whole other issue. But we're here, we'll help, so that's what we're here for. Yeah, you're very, very welcome. And we'll go a little more into that as well in just a bit. So using non-invasive devices, the most important thing about the non-invasive devices that we figured out was titration of the settings. No two patients are alike. There are no two patients alike. Everybody that's in here right now, if I put you on a non-invasive device right now, I'd put each and every one of you on different settings. So it's very aggravating to see patients come in and I see 5 patients and they're all on the exact same settings. It doesn't really work that way. We're all a different size, we're all a different height, we all take in different tidal volumes, we're all in a different stage in our ALS process as well. So settings should not be a set it and forget it type of thing either.
So that term you're throwing out,
Yes.
all patients, important for the device to be titrated?
Titrated.
What does that mean?
So titration of settings means custom tailored to the patient themselves is basically what that means. So these settings will need to be changed on a monthly basis depending on how the patient's doing. It's always important that we stay one step ahead of the disease. And unless you're 100% familiar with this disease, then it doesn't work on the other 99% of the other patients. But prior to me getting into just doing ALS, which is kind of unheard of, because there isn't a company that exists like us that only specializes in patients with ALS. So prior to me doing this, I had dealt with some patients with ALS, and I did exactly what they told me to. They told me put them on the machine, they told me program these numbers, and walk away. There was nothing that we could do for them. And so I always thought that of this disease. When our founder, Keith Sanborn, first started Respiratory Quality Services, he's a respiratory therapist as well, and he was in the hospital dealing with these ALS patients. And he would hear the frustration from the physicians saying, I don't know what to do. I can't be with the patients at their home, and the companies that are out there right now, you give them settings and they just show up and they're literally there to check the machine. They're not there to check the patient. If the machine is working properly and the patient's not breathing right, then go see your physician. That's a typical answer that they get. How long does it take for you to go in and see your physician? It's just not feasible. They would tell the patients call 911 and go to the emergency room. And then when you walk into an emergency room and you tell them you have ALS, I mean, it's almost a deer in the headlights look.
They don't know what to do either.
Exactly. What we started doing is we started arming the patients. We've tried doing the going around to all the hospitals and doing lectures and doing speeches and doing seminars similar to this and showing the physicians what to do in the event that a patient with ALS does come into the emergency room, the do's and don'ts of it. It doesn't work. They don't see enough of these patients. They have all the other patient population that they could deal with, that if they did all that stuff to those other patient population, they would be okay. This 1% of the patient population that's out there, it would not. It would do more harm than good. So we started arming the patients, the family members, with as much information as we get. That way, if you do present to the emergency room, you have the facts, you have the information, you tell them what you can and cannot do at that point. And that seems to be working out tremendously. And I'll give you a little bit more information on that as well, so that you can take that home with you as well. Okay. So there's multiple interfaces with these non-invasive devices as well. And so it's real important that we try to give these patients numerous interfaces as well. These patients start to become very dependent on this equipment. They start to use it 18, 19, 20, 22, 23 hours a day. And so you can't just leave them with one mask across their face because they start to get skin breakdown. So we really need to alternate between a full face mask to a nasal mask to another full face mask that goes under the nose. Whatever it takes to get this patient to be 100% compliant and for it to be comfortable for this patient. But I do know how it is out there when a company tells you, well, I already gave you a mask, I'm not gonna give you another mask, and that's just a whole other issue. We don't play that game, we don't do that. It's a quality of life for the patient. We're really, truly trying to make this a better experience for them as best as we can. Mouthpiece ventilation, in case you guys haven't seen this, we tend to use this a lot on our patients. It's a great device for patient comfort. I have some patients who are on the ventilator 24 hours a day, and every day they will take the mask off and go on mouthpiece ventilation for about an hour or two. It does take some getting used to, and I do know that a lot of times it's a psychological issue with the patients where they get very scared once they take off the mask and all of a sudden get a little tube to breathe off of. But once they get used to it, and especially initializing this early on in the disease process so they can get used to it, it's a big comfort to take every mask off and just have a little tube hanging right there, and you can just suck in a big deep breath. It'll give you really good lung expansion, and then when you take it off, speech is actually improved as well. A lot of patients with ALS, when you start listening to them talk, they start to use 1 and 2 words instead of using a whole sentence, right? Why? Because it's hard for them to suck in a deep breath. It's hard for them to get the words out, so they go, "Hi, thank you for coming." Instead of taking one big deep breath out of this machine, and now you can talk without ever taking a breath. You're still talking. I still haven't taken a breath, and I'm still talking. Some patients who still work, yeah, there's some people who probably don't want that, but yeah, right. Yeah, it's a patient comfort. It's a quality of life. It all goes back to that as well. When we're sitting there in a conversation with the whole family and he or she wants to join in, it'd be nice if they could join in and keep up, okay? There's some patients that we have that still work as well, and they're on the phone. So we set up this equipment, we take it into their office, we set it right by their desk, we put a little arm on it, and if they do have to answer the phone, they can suck in a big deep breath and still talk. So this can aid with that, along with good lung expansion, because it will help expand the lungs, keep them really nice and healthy, going back to what we talked about a little bit earlier today. Cough assist device versus vest therapy. So 6 years ago, roughly 6-7 years ago, Medicare would allow for a CPT vest and a cough assist at that time. And all of a sudden, one year they came out and said, well, these are like and similar devices, so ALS patients can only have one or the other, but they can't have both. So we started looking at these devices to determine which one is going to be more optimal for the patient. So CPT vests work great. They work to shake the patient up. They loosen up all the secretions, but now I tell the ALS patient, now cough it out, and they go, ugh. So here lies a problem, where I've shaken the secretions up, but I just can't get them out. So now we go to cough assist machine, and the cough assist will give you one big deep breath in, and then it'll start to suction and bring up the mucus up into the upper airway. They either swallow it or you can suction it out, whichever of the two, but we get it out of the lungs. So we tend to go more with cough assist device than we do with CPT vests. You're only allowed to have one in a 5-year span. So if for some reason it's a new diagnosis, they have a new physician, and that new physician says, okay, here's a CPT vest, take it, and they get that CPT vest, and you no longer can get the cough assist device for up to 5 years. So it's a big problem, especially if you're not familiar with this disease, then some physician or anyone could write an order for the wrong device, and then all of a sudden it'll really put the patient in a little bit of danger with not having a cough assist device. Good thing about Mr. Keith Miller and the ALS Association, which we utilize them a lot, is we get a lot of donated equipment. And so if that did happen, we will tend to utilize some donated equipment and let the patient borrow it and stuff like that. So there's always some way that we can still help the patient out. We do that as a services for the ALS Association. We will work hand in hand with them. So at the moment that a patient requires some equipment, doesn't have insurance, whatever issues they're having, we don't worry about that. We get the patient what they need. We look through our loan bank. We get the patient what they need immediately. We don't wait around. With this disease, we don't have that luxury of being able to wait around for stuff like that. It's not. And it's surprising and aggravating to see when a patient needs equipment and the company is taking 2 months, 3 months, 4 months to get the patient what they need. This is life or death here, and there is no time to wait.
Today.
What's that?
You need it like today.
You need it today, right? Oh, you needed it last week.
Yeah.
Because a lot of times you're misdiagnosed. And when a patient is misdiagnosed, this has been going on for a while. They're looking for this diagnosis. And when they finally get this diagnosis and they go, okay, now you need all this equipment, and then they send it over to a company takes 2 months, 3 months, a week, 2 weeks, 3 weeks. It's just unacceptable. It's unacceptable practices. We need to get to them immediately.
Never going to happen here.
That's right. Well, that's what we're here to try to prevent all that from happening. So that's a little bit of a differences between cough assist versus vest therapy. Now, cough assist titrations. This I can literally talk about for about an hour and a half or 2 hours. So I'm not going to go into it that in depth, but this is some of the findings that we have found within our company with our researchers that we have hired to do all of these studies. And so what we've done is we've been studying the cough assist to make sure that we can provide the best treatment and titration for the possible cough assist. So inside the cough assist machine is an SD card. And so for years when we started doing cough assist with these ALS patients, we kept looking at it going, hey, there's this SD card in there. What does it mean? What does it do? We got with the manufacturers and asked them, can you explain to us what these SD cards are? Well, the engineers put it in there, so it just gathers information. Well, what does the information mean? So that was a reason behind hiring our researchers to look into this and start digging into this. When we talk about respiratory therapy, us as respiratory therapists, we're very familiar with ventilator graphics. We can look at a ventilator and look at graphics to determine what's going on with the patient and make changes based on some of the graphics. So when we dug into these SD cards, we pulled them out and we started looking at them, we started downloading them, and then we started opening them up and seeing what the patient was actually doing. Now we needed to do an interpretation to see what all these graphs exactly mean. Well, after almost 2 years, we figured it out. We brought Respironics back into our company, and we said, have a seat. We're going to show you now what these graphics mean. They were in awe. They couldn't believe it. We figured it out. It's probably a tool for them to sell these things now. I don't know. But it was great findings on this stuff. We can now literally see what the patient is doing, and we can now literally titrate the settings based on what that patient was doing. Okay? We give all of these patients an inspiratory breath with this cough assist machine. So they take one big deep breath in. Anyone golfing here? Any golfers? So there's always golfers everywhere around, right? So we all know who Tiger Woods is, right? We all know who he is. Has anyone ever seen Tiger Woods take a long swing back and hold it, and then go down on the ball and hit it really hard? No. The answer is no. What Tiger Woods and every other golfer does is they grab that stick, they go back, and then they come down on it really hard, and they hit the ball, and they get longer distance. If that golfer was to pick up that swing and hold it, and then go down on the ball doesn't go as far. Okay? This is just an analogy here. So, on the cough assist machine, what we found is that when we give that patient an inspiratory breath, and they're full of air already, and we cause the patient to pause before we go into the suction mode, the peak cough flow, meaning how much force I actually have to cough out, goes down. So when we looked at all this data, we looked at it and we said, okay, well, we see that the patient's full now, but if we keep them full, and then start going into the expiratory phase, their peak cough flow isn't that high. So what we did is we said, well, we can see that the patient's full right here after 1.8 seconds. Well, how about we just shorten his inspiratory time to 1.8 seconds? So we did that. And then we redid the graphs again. When we did that, peak cough flow just jumped up. Got really, really good, which means the patient can now clear secretions effectively because that peak cough flow went up so high. So once we did that, peak cough flow went up really high, and all of a sudden, for some strange reason, patients are no longer having atelectasis and pneumonia and are living longer. It's really weird how that works. But it's because we're giving them a really good peak cough flow and utilizing this equipment the way we should be utilizing it. So we make that little change on it, and now the patient's doing so much better. Whenever they do go to cough a little bit in the machine, peak cough flow is really high, it looks really good, patients are able to mobilize secretions if they have secretions. If they don't have secretions, you continue to use the equipment because that just tells me your lungs are still healthy. You need to keep them healthy. Don't wait until you have secretions to all of a sudden start to learn how to use this equipment.
How often would you use a cough assist as opposed to like BiPAP or?
Well, I would use the cough. We teach every patient to use the cough assist at minimum twice a day. You have to do the exercise. In the morning when you wake up, in the evening when you go to sleep. Now, if you do start to catch some type of respiratory infection, because that can happen, and you start to build up some secretions, then do it 3 times a day or do it 4 times a day. There is no overutilization of the cough assist machine. So you want to use it as much as you can. Bulbar patients, very, very, very tricky. So what we found is years ago, they used to tell us that bulbar patients have a reaction to the cough assist, therefore they don't get cough assist, they only get the CPT vest. And then we would go back to the same thing. We're like, yeah, we gave him a CPT vest, but we shook him up. Now he can't cough it out. So which do we do? And it was true that they were having glottic closure. Since a bulbar patient is completely in the upper airway, they've lost musculature in the whole airway. So whenever we would give them whenever we would start sucking on the machine, on the cough assist machine, it causes glottic closure. Their glottis closes, and then they have a reaction. They can't breathe. And they start coughing, taking the mask off. They go, oh, no, I can't tolerate this. And they're coughing for a good while because they are having a reaction to it. So we started studying bulbar patients. When we started studying these bulbar patients, we started realizing it's not the inspiratory breath that they're being affected by. It's only the expiratory negative pressure. So what we started doing is we can see on here where there's glottic closure now. So based on the graph, we can look at it and say, hey, I'm having glottic closure right here on exhalation. Not on inhalation, but on exhalation. So we started increasing the pressures on inhalation so that they can get their lungs really, really nice and expanded. And then we started decreasing their negative pressure until we stop having that glottic closure. So that negative pressure, we may start at negative 30, and we may go down to negative 25, 20, 15, whatever it takes until we stop seeing that glottic closure. So there's some patients that we have the negative number down so low because their bulbar is so bad, but yet you look at their peak cough flow, and their peak cough flow is still significant enough to remove secretions if they needed to. So there is a way now that we can now utilize these cough assist machines on bulbar patients without having that effect on them. But it's very complex. It's not as easy as, oh, just go over there and kind of put them on the machine and walk away. It doesn't work that way. And the disease process is going to change as well. So we just need to stay on top of it. But there is ways that we can help bulbar patients with this now. So we're currently working on publishing our findings right now. We actually just received some notice back, and we're still working with ARC and I think chest physicians to try to get all of this information published. So again, it's imperative that the settings be done properly for the best therapeutic effect. So one of the other things we realize is, you know, that negative pressure that we use to help suck out the mucus? Well, we can actually see on there when the patient's lungs are empty. Okay, so now we looked at it and we said, okay, well, this patient's been on the cough assist for a while, and we look at it and we see, hey, after 2.2 seconds, the patient's empty. But we have it programmed to suck for 3 seconds. So what do you think's happening after we finally got the lung open? We sucked out all the mucus, if there's any in there, and we continue to suck. We've done everything that we've been talking about that we need to do, which is expand the lungs. We want to expand the lungs, expand the lungs, expand the lungs, and now we just sucked them and collapsed them. Very, very bad. We were doing this. I'm guilty as charged, and we were all doing this, all because we didn't have this information. But now knowing what we know, it's our job, it's our due diligence to make sure that we don't do this anymore. We found a solution to help the patients.
So how do we find somebody, because we have these devices now,
Correct.
and like the cough assist is not doing anything. So
Right.
obviously now I'm
Right.
saying
Help.
it's not working
Yeah.
because
Of course.
settings are probably not
Right, correct.
And then where do we go for help on that? And
So you will now, for now,
Yeah.
I'm off the boat 2 days ago. Notify Keith Miller, and then
Yeah.
we'll work through your physicians, because we need to get orders as well.
Yeah.
But we'll work through your physicians. At this point right now, it's not about us coming in and just taking over. It doesn't really work that way. We're really here to help the patient out as much as we can. If you have your device and you already have it, it's already in your home, then we'll get orders. It's most likely already patient owned. I'll get orders to titrate the settings, and then we'll come in the home and we'll just titrate your settings. That's all there's to it.
Because I called in and said, oh, this isn't working,
Yeah.
what do we do? And, oh, well, have you, did you check the setting? I'm like, when they come and deliver it, you're, sort of in crisis mode. When you get this stuff and you're trying, because it is, like you say, you're in crisis mode and you get everything and they show you and you're like, okay, let's do it. 2 weeks later, you're like, okay, now we're not in crisis mode,
Right.
but how do we use the equipment
Correct,
now? And
correct.
they're like, oh, well,
Yeah, you're on your own.
exactly.
Yeah, I see it. It's not just an issue that I hear this 1,000 times. It's the most frustrating thing that I've ever seen. So we're here to help. You're going to get some help. One way or another, we're going to find some way to help you. So we're going to make that happen for you. Be a little patient, because probably everyone will need some help. But we'll definitely try our hardest to make this happen. It all started, again, from one conversation that I had at the bar with Keith Miller. And my wife said, drinking will get you nowhere.
It did.
Yeah, I don't know if that's quite the voice. It's pretty similar. At least that's what it sounds like in my head. But she said, drinking will get you nowhere. She always tells me that. And this one time, just so happened I was at the bar, and I'm talking to someone, and I meet Keith, and 8 months later, I'm sitting here. So we've gone from the whole state of Texas, which we service the entire state of Texas, about 600 patients with ALS that I have on service right now, and now opening up brand new here in San Diego. So I'm glad to be here, and there's definitely the need. But literally, when we've done these presentations like this at a national level, I can literally now throw the dart at the map and drive there. There's someone that needs help. Because this information's not there. It's not there. There's so much more that we can do. We're not the doctors. We're not the neurologists. We're not the chemists. We're not the scientists. In other words, I'm not coming out with a cure for this disease. We're not. Our company is not. We don't have the resources. There's no way. We're playing at a total different level. But what we have done is we've done this. We've taken ownership of what we do. Okay? And what we do is we're respiratory therapists. And if we're going to jump into this field, then we're going to master this field. And we're going to do it to the best of our abilities, because this disease is considered an orphan disease. Okay? It being an orphan disease, no one's concentrating on this disease. They're concentrating on all the other diseases where there's millions and millions and millions of patients that are being affected by it, like cancer. Okay? And I get it. But if we're going to jump into this, we're going to jump into this with everything we've got, and we're going to do it the right way, because it's the right thing to do. It's the right thing to do for the patient. What's that? You know, once you're affected by it, you start to realize all of that. But if you're not affected by it, you go on with day-to-day activities and day-to-day life. We work very hard with the ALS Association to get a lot of legislation changed, a lot of these rules changed. Why is the rule that we have to wait until an ALS patient hits 50% of their vital capacity before they can be given all of this equipment? when all the studies show that the earlier the patient's on the equipment, patient lives longer. We already know they have the disease. Why do we have to wait until they hit 50% of their forced vital capacity to get them the equipment that they need? You know, it's just, these are all the things that we're fighting. These are all the things that we're fighting in Washington, D.C. These guys send someone to Washington, D.C. every year to go over there and fight for the patient's rights. And they have made some progress. They've made lots of progress. It used to be a patient used to have to wait a year before they got their Medicare benefits when they've been paying into it their whole life. Now it's what I think a 5-month wait. So they've gotten that down. The 5-month wait to me is still too long as well. Why do I have to wait 5 months to get my benefits that I've been paying into and have earned my entire life? It's crazy. But these are things that they continue to work on. It's very frustrating, and I can hear it in your voice. It is. It's very, very frustrating, but we're here to help. We're hoping to make that as big of an impact as we've made in Texas, we're hoping to make it here. And I hope we do that for you. This goes over cough assist graphics again. I can tell if the patient's mask is not on tightly. So when I do it with the patient, I slam it on them and it's tight, and I'll even ask them, am I hurting you? No, I'm not. The moment I leave, family member will go to them and, oh, let me just kind of put it on you. Doesn't work. Nothing works if there's a big mask leak on there. And so when I come back, do a download it under our computer, I can tell, hey, whoever's doing this isn't giving you a really good mask seal. So, but again, we're able to catch it, we're able to see it, we're able to rectify the problem, and we're going to catch it. So, effects of improper CAD settings, the cough assist settings, we kind of talked about that already, where we can de-recruit the lungs, and we can do more damage than good. We also started to initiate, just in case that is happening, we started to initiate a third settings on the cough assist machine, because it does have 3 settings that you can program on there. So we have a settings 1, we have a settings 2, and then we have a settings 3. And I'll show you how to do all those settings. But on the settings 3, we started to incorporate what we call a long, slow, deep breath. We kind of labeled it LSD, but it's not sounding right. So, because we're telling everyone to get on LSD. But it just basically stands for long, slow, deep. And so what we've done is at the very end of your treatment, we ask you to go to the third settings, and we'll ask you to take a couple of big, huge, deep breaths assisted by the cough assist machine. So it's just going to be expand the lungs for about 5 or 6 seconds. Keep them open, keep them open, keep them open, keep them open, keep them open. Take the mask off, and the lungs will go back to normal. But that will assure that if there is any kind of de-recruitment with the cough assist machine, you will get them completely inflated and completely distended and give you really good therapy right after that. And you only need to do about 2 or 3 breaths of that as well. So what is the role of oxygen in a patient with ALS? So we talked a little bit about this because we kind of jumped the gun at the very beginning. But you know, out of 600 patients in Texas, I would say maybe 3 or 4 of them I have on oxygen right now. Out of all of them, 3 or 4. And that's because they have COPD as an underlying disease. Okay, that's the only reason. But it's frustrating for me to go out there and see a patient with ALS come into a clinic or come into anywhere, and they're bleeding in all this oxygen, and they're on their non-invasive device, and I go, wait, what's going on here? Why are you on oxygen? You have COPD? No. I have ALS. And I'm going, yeah, I know, that's why. Why are you on oxygen? Well, then I'll go and I'll check their ventilator settings, and it's clearly seen that their ventilator settings are very low. And if their ventilator settings are very low, then they're not getting full lung expansion. Then, of course, you need to oxygenate all the top portions of the lungs that you are using and compensate by giving them all this oxygen. But have you really rectified the problem? No. I had a patient not too long ago that I went and saw, and this is exactly what was happening. Really, really low volumes. He's 24 hours on the ventilator, and he's got 5 liters of oxygen being bled in the entire time. So I went out there, checked his ventilator. I go, there's a problem. I can see it clearly right here. I go, you mind if I make the changes? So got orders to make the changes, made all the necessary changes, took the oxygen off. Prior to me making the changes, his oxygen level was 92% with 5 liters of oxygen. 92% is decent oxygen level. But with 5 liters of oxygen and a ventilator, that's really, really bad. So took the oxygen off, made the necessary changes on the ventilator. He immediately felt the relief because he doesn't have to work for that breath anymore. The ventilator took over and started working for that breath. His respiratory rate went from 22 breaths per minute down to about 15 breaths per minute because he's getting twice as much volume of air into him. All of a sudden, his oxygen level goes to 98%. from 92% with 5 liters of oxygen to 98% with no oxygen. It was all in the settings. Settings were just wrong. So it's really clear that when a patient has low oxygen levels, what the oxygen is, what the problem is, and the problem is he needs lung expansion. We need to get the lungs expanded. Question? Okay. Tracheostomy and invasive
Okay, now we'll
ventilation.
go back.
Okay.
So, on the East Coast, it's more common for ALS patients to be given oxygen than it is in the West Coast and obviously in Texas.
Right.
But at least there, patients are using their BiPAP overnight.
Mhm.
Why is that important? What's going to happen with CO2 or?
So CO2 retention,
Filtration
right.
process.
So it all goes back to, even from the beginning, from what I've been saying about low lung volumes. Low lung volumes can lead to higher elevation of CO2, especially at night. When an ALS patient goes to lay down flat, even for us, it's twice as hard for our diaphragm to contract and get that air into us. So they start to breathe really shallow. They start to have CO2 starts to build up, and we need to remove that CO2. So 2 things are happening with a patient with ALS at night that we need to do. We go on non-invasive device at night, one, for lung expansion, to keep the lungs open, let the machine do majority of the work, preservation of the diaphragm, and also for CO2 removal as well. So that's the importance of using it at night, because otherwise, if you overwork that diaphragm, for us it's fine right here. If we go to sleep at night, and yes, we will have a little bit of atelectasis happen overnight, but the moment we stand up and we start walking, our lungs expand and they pop open again. For an ALS patient, are they going to get up the next day and start walking around? Some can, some can't. But it is twice as hard for our diaphragm to work out at night. So what do you think is happening with this muscle disease if you overwork any of these muscles? Any of them? There's no physical therapist out there who deals with ALS, at least, that should be telling any patient to grab a bunch of weights and start to build muscle, right? Because it's not going to happen. First of all, it's going to do the opposite effect. You're going to break that muscle down, and you're going to wear it out even quicker. So I've seen one patient go from walking one day to not walking the next day. And he was walking with a walker, but he went and saw a physical therapist that did not deal with ALS, and the physical therapist said, I'm going to work you out, and we're going to get those muscles back. And so they worked him out, and they made him do squats, and they made him lift all these weights, and the next day he was so sore that he couldn't get out of bed, and the following day he's not walking. All because he got information from a therapist who is not familiar with this disease. So if you overwork any muscle in your body with this disease, you're going to wear it out. So you need to use your non-invasive device, especially at night. It will compensate and make its necessary changes that it needs to based on the position of the patient as well, if the settings are set up properly as well. The more you use it during the day, the better as well. Again, you're preserving that muscle, you're getting good lung expansion. So some patients will sit there and tell me, well, but I breathe fine all day. Well, that's fine, but you're still using your diaphragm, you're still using your intercostal muscles all day. Why not, if you're sitting there watching TV, why not put the mask on? Now, I get it. If there's family over, you're having conversations, yeah, take the mask off, put it to the side. But if you're going to sit there and read a book, or you're going to sit there and watch a movie that takes 2-3 hours to watch, put your mask on. Why not? And especially if you take naps during the day, you'll see that as this happens, you're going to start to see that the hours of usage on these non-invasive devices are going to continue to increase and increase and increase as this disease process moves along, because they're going to feel it too. They're going to need it. They're going to tell you, yeah, I need to go on it. I'm getting a little tired. I'm getting a little winded. You see a lot of patients that you're yawning all day long with this disease, and it's just a classic sign that they have alveolar collapse, and they're yawning to try to get that lung expansion. But I see it a lot with these patients. Now, you get them real good lung expansion, all that kind of goes away. It's crazy how that works. But so tracheostomy, there was a study that I had read up on, or a survey that I had read up on, that showed, roughly 95% of patients do not elect to go invasive, and I get it because it's a different quality of life. Out of that, the 5% that did get trached, it wasn't even because they wanted to get trached. So 75% of those trach patients got done emergently because they didn't have their advanced directives in order. They panicked, called 911, They come in, they find them not breathing, they put a tube into them, and then when they get to the hospital, they wind up with a tracheostomy. And all of this is done, some of it is done from poor planning, some of it is done from not having the correct information as well. What drugs can we take? What drugs can we not take? If you present to a hospital and you're in pain and you fell down and you hurt your elbow, can you be given morphine? Can you be given opioids? Can you be given anything that suppresses your respiratory drive? And the answer is no. But you, the patient, and the family member need to know this. Because do not expect to go into a hospital and that nurse or that physician in the ER is going to know this information, because it's not true. So this is the part where we need to arm you with as much information as we can, so that when you go in there, you say, hey, hold on, I have ALS. I cannot lay flat. Because a lot of times they want to lay you flat to do an MRI. And you go, no, 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 I can't lay down flat. I can't breathe laying down flat. Oh, we'll get you to breathe laying down flat. We'll get you to tolerate it. Watch. And they give you some fentanyl or some Versed to try to calm you down. Now, for us, that's fine. That will work for all of us. You know, my wife's been a nurse for 15, 16 years. And when she hears me say this stuff, she sits there and goes, oh, my God, I did not know that. It's not anything that they're teaching anyone in nursing school either. They're following a protocol. The protocol is, if you're going to get an MRI and you have anxiety and can't breathe and, oh, you can't tolerate it, then give them a little bit of medication to help them tolerate it. That doesn't work for a patient with ALS. They need to be put on a non-invasive device that is MRI compatible. They do have them. I've worked in a hospital. We have ventilators that are MRI compatible. And you need to be put on a non-invasive device to tolerate laying down and being put in there to do the MRI or the CT scan or the X-ray or whatever. So you need to arm yourself with as much of this information as you can. Respiratory issues to watch for. Obviously, if the patient can't breathe, you can see that on this diagram. You'll see a little bit of breakdown on the bridge of the nose. That's going to happen from a lot of use of non-invasive device. But that's the reason that we need to, first of all, make sure that we're not over-tightening the mask. And secondly, switch from devices, from nasal device to full-face device and back and forth. Nasal devices we typically use during the day so that the patient can still talk. And then full-face devices are usually more optimal for patients at night. If you have a trachea, you would obviously look for infections around the trachea. High body temperature can really be a good sign of pneumonia as well.
So for our listening audience and those who play this later, when you talked about the tight mask, we were on the cough assist machine.
Correct.
And for the
non-invasive device, nice, good, loose. You should be able to still fit a finger in there. If you can't fit a finger in there, it's on too tight. There's also ways that you can, depending on which ventilator you're on, you can look at it to see what the leak compliance is on it as well. So if the leak is too high, then obviously you're not getting the breath and the air that you need as well. So you want it to fit. You really need us to go in there, a respiratory therapist, to go in there and show you how it should be done and how it should fit and work out all the kinks on it. But it should not be put on too tight. You're definitely going to get a lot of skin breakdown as well. If you use a non-invasive device for 8 hours and you have skin breakdown, it's on way too tight. If you use a non-invasive device for 20 to 24 hours and you love that mask and you don't want to do with any other mask but that one, even if you put it on lightly, yes, you're going to start to have some skin breakdown as well. Hydration is important with this as well. So the more hydrated you are, less chances of skin breakdown as well. And I know it's hard. Some patients can't swallow. That's what feeding tubes are for, and we're going to talk a little bit more about that as well here in just a bit. So here we are. Feeding tubes. When's the proper time to put in a feeding tube for a patient with ALS? We talk about this. I know that this whole conversation is supposed to be about breathing and the effects of breathing, but this is a huge effect on the respiratory side of it as well. So a lot of times we recommend feeding tubes to patients because they can tolerate the anesthesia to put in the feeding tube, not necessarily because they can't swallow. And so that's a big confusion with a lot of patients because they say, well, I can swallow just fine. Yeah, I know you can swallow just fine, but when we do your respiratory testing at the clinic and we do your forced vital capacity and your forced vital capacity is dropping, it's a really good indication that you will not tolerate anesthesia to undergo the feeding tube placement. So we don't always just look at can you swallow, we look at can you tolerate the procedure of getting it done. So once that's done, it doesn't mean you have to use it. I've had patients that have had the PEG tube put in and not used it for a year. You just have to keep it clean and maintain it, flush it every now and then to make sure it's patent, and that's about it. But you can continue to swallow for as long as you can, and it's highly encouraged that you do. A lot of times chewing steak and chewing bigger pieces of meat and all that stuff, it takes a lot of work. And what's happening is, you know, the patient will even tell you, yeah, this has taken me a long time. They go from a 30-minute meal to a 1.5-hour meal, and they're still chewing. They're also wearing out the muscles in the mandible. They're wearing out a lot of muscles because they're doing a lot of work. So what typically starts to happen is you start to see a lot of weight loss as well. And when you start to see that weight loss, two things are happening. When your respiratory side of you starts to increase, your respiratory demand starts to increase, your metabolic rate starts to increase as well. So when you start breathing really heavy, you start burning a lot of weight because your metabolic rate starts to go up. So patients with ALS who start to eat less, because they don't want to take an hour and a half to eat, oh, after 30 minutes I'm done. I'm just done. Whatever I ate, I ate. If you have a feeding tube, you could supplement that with nutrition and say, okay, well, you ate half a meal, then I'll give you 1 can of the Longevity to kind of supplement that and keep the calories up. Because when your respiratory side is working, you're burning a lot of calories, so the higher calorie intake that you can take in, the better. It's been proven over and over again that the more weight you lose, the smaller you are with this disease, the quicker the disease process is going to go. It's a fact. So we want them nice, big, healthy. Yeah, that's why me and Keith are on that diet right now. It's not working for us, but yeah. But
you don't have ALS.
But I don't have ALS, right. So, but that's the whole theory behind all of that. So dietary is very, very, very important with that. And so for patients who do have feeding tubes, there is a way that you can vent your feeding tube as well. So venting the feeding tube, when you're on a non-invasive device and you have bulbar, even if you have limb onset, at some point you're going to have bulbar involvement as well. And so patients who cannot control their epiglottis, and that's what controls food from going in one way and air going in the other way, whenever we put you on a non-invasive device, it can cause some abdominal distension and abdominal discomfort. And having a feeding tube can aid with releasing all of that gas and air out of there. So this is the process for doing that. If anyone wants a copy of this, I'll give you my email address at the end, and I can email this out to you guys if you don't know how to properly vent a feeding tube. But I've got many patients that in the morning when they wake up, they've got big abdominal distension. They get the wives or husbands come in, they vent the tube, and immediate comfort will come from relieving all of that pressure. So I had a patient who can swallow just fine, but was having abdominal distension, stopped using their non-invasive device. They were using it for 6 months straight, and they loved it. They did so great, but they stopped using it because of the abdominal distension. But they could swallow just fine, and their forced vital capacity hadn't been dropping either. That patient, we had feeding tube put in just for that reason, for venting the tube. They're going to need it at some point anyway, so it wasn't a bad thing, but they felt immediate relief from doing that and became compliant with non-invasive device immediately again following that procedure. So it can really help out with that. So things to watch for are things like infections around the stoma site. You can obviously tell which one's infected and which one's not, right? Doesn't take a scientist, it doesn't take a nurse, it doesn't take a doctor, it doesn't take anyone. Anyone can clearly look at this stuff to tell if there's an infection with this. Invasive procedures. Now that we have Radicava out there, and a lot of patients are on Radicava or may not be on Radicava, I'm not sure about out here, because some physicians are still not writing for it. But putting in a portacath placement is also considered an invasive procedure. And when patients go in and do a portacath placement, they do lay them down flat, they kind of extend their neck out. Do you think some of these patients are going to have some difficulty breathing whenever you go and put this portacath placement in? Yes, they do. And guess what the typical nurse's protocol is again? Just like the MRI and the CT scan. It's the exact same protocol that they go through, okay? Now, realize one thing. These nurses and hospitals and everyone has never put a portacath in on a patient with ALS. Why would they? It's never been needed before, ever. So now all of a sudden they're getting an influx of patients needing portacath placements in these hospitals and outpatient procedures, but anatomy is the same. So the procedure for doing these things is exactly the same for you, for me, for everybody else. It's exactly the same. However, they're not familiar with this disease process.
So, quick question for Keith. Do you see a lot of patients on Radicava and how effective it is?
There is probably 25-30%
On Ra-
penetration of Radicava with our
Out here?
population.
Gotcha.
Have you noticed a long-term benefit, or is
You know, it's very specific by individual. We have some folks who are very clear with their perception of benefit, and we have other folks who have stopped treatment because they couldn't. The offset to the schedule, 10 days
Right.
on 28 for an hour
Mhm.
versus their perceived
Correct.
efficacy of the drug, some people drop off. But it's a mixed bag out there.
Yeah, they're looking deeply into this right now on the efficacy of it, and trying to gather as much data as they can right now, at least for probably the next year or two, to see if it's really stopping the progression of the disease by going back and looking at the ALS-FRS score and tracking it to see what is the progression, or if it is progressing or if it's not. So
it
it's
is
still
difficult because every patient is different.
absolutely.
Exactly. And MT Pharma recently announced, this is public domain information,
Correct.
that they're going after biomarkers
Right.
so they can have scientific evidence of the slowing down or not
Mhm.
of the drug. So that's going to be helpful to all of us because right now the functional rating scale, that's pretty subjective.
It is very subjective, and a lot of patients who are on, you've all heard of the placebo effect, right? And so a lot of patients who are with this disease, we're in survival mode, and if you're given water that says it will cure it, then in your mind it's working. I feel better, and so this is the hard part. Yeah, which is a great thing. It actually is. It actually is. Even when you start talking about diseases like cancer, when you start talking about diseases like cancer, attitude is everything. The greater the attitude, the longer you're going to live. That's just the way it is. So it's all in how everybody takes it, and that's why these biomarkers are really important, because a lot of it is just subjective. You were asking an ALS-FRS score, you're asking them all of these things, and did it progress or did it not based on that score? Who knows? So these procedures, I've actually have had a couple of encounters with patients who went in for a portacath placement and did not make it out of the hospital.
Because of respiratory
Correct.
issues.
So patient was anxiety and couldn't tolerate laying down flat, and nurse gave him some medication, and next thing you know, he stopped breathing, and code blue is called, and patient didn't make it. So once
She won't do that again.
What's that?
She won't do that again.
She won't do that again. Right. Well, they take it for granted. Again, they've not dealt with these patient population before. No one has. And all of a sudden you start doing these procedures, it's very, very tricky. So all this required was a patient taking their non-invasive device with them to the procedure, having it on, laying down flat, leaving the mask on, and you'd have been just fine without any kind of medications and all that stuff. So once we found out about the first patient with this, we came out with, we designed our own protocol, and we put a protocol together. I think I sent that to Keith already. So in case there is a patient that's going to get this procedure done, Keith has the protocol already that we kind of wrote up for them, for the patients. That'll give you all the do's and don'ts of putting in this or having any of these invasive procedures done.
So are you saying that the sooner you have a portacath placed?
Portacath placements are only needed if you're going to take Radicava.
Okay.
Only for Radicava patients. But going back to PEG tube placements, yes, sometimes the sooner the better. Tends to work out a lot better as well. Mobility, as you can see, this guy, I love this picture because the guy's, you can't stop this guy from doing anything. He wants to mow the grass, he's going to mow the grass. Having mobility doesn't mean you can't do the things that you love to do. There's foot controls, there's eye gazers. For mobility reasons, we also attach a ventilator to the back of the wheelchair, so that we can get the patient out and into better quality of life, getting them out of the house. Patients who have motorized wheelchairs do qualify for a second ventilator that's attached to the wheelchair, to the motorized wheelchair. And this is very important to help the patients improve the patient's quality of life, and you're no longer confined to your home. We used to visit patients who we used to go into their homes, and they haven't left the home for months. It's very difficult to get them out into the field. But all of a sudden, I attach a mouthpiece ventilation. I'm like, would you do this out in public? Yeah, I'll do that. A lot of times, having a mask on your face out in public, it can be a little difficult. You start to see people looking and staring and seeing what it is, but a mouthpiece, a little straw that comes out of the back, that can really help get a patient out. Can make a big difference in the patient's quality of life. Speech devices, you guys have all seen it. Importance of speech devices for me is that we're always in the home. We go into the home every month, titrate the settings, see how the patient's doing. I go, Mr. Smith, how does that feel? Oh, it feels great. You know what? Well, let me make one more change, and I make another change. Does that feel better or does that feel worse? No, that feels a little worse. Okay, let me go ahead and go back, and let me go back to that settings. Well, all that goes away if all of a sudden the patient has zero speech. Then I go, okay, well, bring out your speech device and go ahead and let me know on your speech device. Oh, well, I got the speech device a year ago, and I never learned how to use it. Because at that time, I had fairly okay speech, so I didn't need it. But now the time that you do need it, you can't even communicate with me, and it becomes very, very difficult, even for myself, to find and titrate the right settings. I can kind of look at it and get really close, but I would love to have some type of patient feedback that tells me, yes, that's it, you're on it. Or, no, it's not. Go back to the way it was. So speech to me is just using these devices when you do get them. It's very, very important for us to help communicate and get these settings done the right way.
I just have a comment on that too. I think one of the really, really, really important things is that it's like you're saying you get the device, but one of the things they don't tell you, because there's a whole breakdown with just in the healthcare industry,
yeah.
they're not familiar with the disease.
Right.
As soon as you're diagnosed, you should bank your voice.
Right.
Period.
Oh
You
yeah,
should
the
bank
voice banking is awesome.
That should be the first thing they do.
Correct.
Just
Well,
like
you know, I
okay.
thought, so I originally at one point had thought that voice banking you do when you get your device. So you get your device and then you start doing voice banking. And then I was completely corrected. I was like, no, no, no. A speech therapist told me, you can start voice banking today and start recording and recording and recording. And then when you do get your device, there is a way that they can upload it into that, which I didn't know that. And, you know, I'm in healthcare too, and I'd been doing ALS for years at this point. And I'm going, wait a minute, is that what it is? And they're going, yeah. Well,
So they wait until you lose your voice.
absolutely. And now
partial loss, and it's
voice
difficult.
banking is no longer an issue. Yeah, or no longer, yeah, you can't do
Yeah,
that.
and like a lot of those things, even with the device that does the eye
The eye
gazer,
gazer.
my husband got, but then we just said that the speech therapist came over and she said, well, they're wheelchair specific to get them out. So
Correct.
I was going to go see Keith
Keith.
and say, okay, what wheelchair would be the best fit
Correct.
before we order the device.
There's a device.
So you
Good to
kind
know.
of have to be really proactive
Absolutely.
in all these things for somebody that's newly
Correct.
diagnosed. Otherwise,
Absolutely.
you're scrambling and you're like, well, nobody told us, but you don't know because
Right.
everybody doesn't know
They don't know.
until too late, and then you're
Right.
like, oh,
Yeah.
had I known this a year ago,
Correct.
it really. But where do you go for that information? And it's really difficult.
Yeah,
because
and you know that's the key role to the ALS Association, being that mediator, that middleman. We have taken a very proactive role in learning as much as we can about the wheelchairs, about the speech devices, about the dietary needs, all of that stuff, because it's very, very important for us. If I'm going to do everything that I can to make the patient breathe, to make the patient live longer, then I want to make sure that their quality of life is good. And all of this pertains to their quality of life. So I can't just do my part and let everybody and go to a patient's home and see that they're struggling and don't have the equipment that they need. I need to intervene. My intervention is going to be going straight to Keith and utilizing my resources, or notifying the physicians and letting them know, hey, I just observed this at the home. Is there any way someone could get out there or do a swallow eval or whatever? I just need to at least observe, comment, and also notify the physicians and let them know what's going on.
we had even the same situation where my husband suddenly was trying to eat, losing a lot of weight, but still trying to eat, but doing hydration.
Right.
So then he suddenly couldn't eat because
Correct.
everything just goes south. It goes south
Correct.
fast. So we got 100% on feeding. Well, we got the pump. Well, the pump wasn't pumping the food that he got. You'd have to add too much water to it in order to get it to flow, so that wasn't going to work. So it was like changing the pump, changing the food, and then the adapter didn't fit his peg, and so but all of these things ahead of time you're like, okay, that's not working, and you have this stuff, but nothing's working, and again, nobody to support you to say, hey, this will help. You're sending pictures to somebody to say what port does he have or what peg does he have. And
Correct.
so there is, like, ahead of time, like what you're saying, to have a service that physicians can contact, or that we were just telling the speech therapist,
correct.
to have somebody to say, here are the resources, to have some service that can check all the boxes, because it's tough.
Oh, it is. It's very, very tough. Yeah, I agree. Hopefully, between the works of what we can do and what the ALS Association can do, we can try to help fill that void and fill that gap. But I see it. I know exactly what you're talking about, So I see it every day, and we try to intervene as much as we can. But we'll be a really good resource to you.
Yeah.
We'll know who you need to contact, who you need to get a hold of, or we'll do it ourselves and just get a hold of them. We need to be the middleman. Anyway,
I'm good.
so.
I'll come help you now.
Good to know. There, I've got an assistant now, Keith.
You're gonna get some calls.
Yeah,
So you went right into the ALS Association and utilizing our resources is exactly what we talked about. It's like you've seen my slide already. But that's exactly what I'm talking about right here. It's just utilizing your resources, utilizing the ALS Association for what we need to.
Saying this out loud, but we asked, should we go down? No, you don't need to do that. By the physician.
Really?
Right.
So, which afterwards I start going back through, because I went onto your website, I printed tons of things, put a whole booklet together. I mean, my husband's like, where'd you get this? I'm like, I printed it out from all this research.
Right.
And then we go in, they're like, no, you don't need to do that. And I don't know if it was a fear, and I think I had spoke to Keith earlier on, and one of the things that really impressed me was, I said, oh, maybe we'll come, and this was earlier on. He said, well, is your husband ready to see somebody with more advanced disease? And I thought, I don't know if I am. I mean, it was a really, really good question, because it stops you in your tracks, because it's a very scary disease.
Yeah,
so,
it is. Very.
But I wish I would have followed my own gut and came down and got more involved. I think it would have made everything much easier. So
Correct.
Anybody out there listening or watching later, I think it's imperative that you do that earlier on.
Correct.
Just to be prepared.
Yeah, I agree.
And that's, if I may, that kind of sharing is exactly why we try and get everybody together.
Right.
Whether it be a harbor cruise or the U.S. Midway or a formal support group meeting
Absolutely.
or a care services information, the
Right.
more we can talk to each other and support each other. And so well said.
Yeah.
Well said.
Yeah, I pick up a lot of, I pick up so much things from my patients and their family members. And when I see them doing certain things in the home, and I'm like, how did you do that? And they're like, well, I contracted this and did that and added this. And I'm like, wow, that's awesome. And it'll be months later that I'll walk into another home and they're having the same exact issue, and then I'll be like, hey, hold on, I've got a solution for that. I saw a patient one time do this, and I start rigging stuff up for them, and they're going, wow, didn't know we could do that. I was like, well, you got to be proactive, and there's no book that's going to tell us exactly how to do these things. We don't know what we're going to encounter sometimes, but we start to get a little creative. And when we see that from we need to share that information with everybody else. So that's the important that Keith's saying, like whenever everybody meets, that's where everybody starts sharing information and changing numbers and call me if you have this, and hey, this is what I did. I called this person, they came out and they made me a ramp for X amount of dollars. Oh, great, that's what I need. So this is where you start to get all of those resources. It's great for that communication. So what we did, and we're narrowing this down to the end, is we kept having a lot of those issues that we were talking about earlier with patients that they would present into the hospital, and the hospital didn't know what to do. Okay, so we talked a little bit about that. So we started saying, well, what can we do to better arm the patient with information so that if this does happen or EMS does come to them, they'll know. They don't need to know about the disease, but they need to read the information that they have. So we came out with a lanyard, pretty big, because I wanted it to clearly be seen. I didn't want, ALS Association had come out with something similar to this, and it was a little wallet packet, and you opened it up and had all that information. But that you'd have to actually pull it out of a purse or out of your wallet, and that just wasn't going to happen. So we kind of fed off of that, and we expanded it, and we made it bigger, and that's what this picture is right here, this diagram is, right? It says, it has the ALS Association, it says my name is, and you put your name in there with a Sharpie marker. And on the right to the bottom of it, it says, I have advanced directives. So if EMS comes to you, they'll know, yes, I do have advanced directives, or no, I do not have advanced directives. It'll have emergency contact person, telephone number, physician's name, who your respiratory therapist is, and what their phone number is. It has my contact information at the bottom, or our company's contact information at the bottom. And on the back side of it, it says, I slur my speech, but I do understand what you are saying. So that tells people you don't have to yell at me. Yeah, I'm not drunk, because they do get confused. Oh, what medications did you take? Oh, what are you on? What you know, because they do mistake that a lot. And it does say, please allow me time to respond. And it also tells them, if my oxygen level is low, please do not give me oxygen. Put me on non-invasive device, and I put some generic settings that they could put you on to kind of just help get you through to the hospital or whatever the case may be. It tells you laying down may be difficult for me to breathe. I will retain CO2, therefore sit me up as much as you can, because sometimes in the ambulance they just want to lay you down and throw you in there. Sit me up, because I will stop breathing from here till we get there. And then it says avoid, and on there it clearly will show you paralytics, general anesthesias, narcotics, muscle relaxants. Would we want to take a muscle relaxer with this disease? Probably not. If used, the ability to rapidly assist with ventilation or non-invasive is going to be imperable. So you can use some drugs to suppress the respiratory drive, but you better be on a ventilator so that it can keep up with you and start to take over the breathing for you. That would be awesome. Other than you're going to wear out that shirt because you're going to have to wear it every day. But if I have a gastrostomy tube, then please administer all oral medications through my gastrostomy tube. So it's simple. I wish I could add information on here that would be pages and pages long, but I had to continue to condense it. And then finally, we figured out, okay, I think this will work. So it's front and back, and it's a lanyard that can go around their neck, or you can hang it on their ventilator, or just hang it somewhere where it's easily accessible. Or if you have to call 911, you quickly grab your lanyard, you put it on them, and now everyone can clearly read it, even in the hospital. So we found that it has worked out pretty well. It's been fairly effective. And I've had a lot of patients that have come up to me and said that has been a lifesaver for them. Because immediately when emergency personnel get there, they see you, they're like, oh, okay, yeah, go ahead and give them some medication. Go ahead and do this, do that. Put them on oxygen, everything that we're not supposed to do. Now, 99% of the time, that will work on all the other patient populations. It's not going to work on this patient population. So it's pretty scary. So living with ALS, these are a couple of pictures that we've gathered over time, because it all goes back to quality of life. One of our patients that's on here went on a cruise recently. Actually, what he did is he found out that one of my therapists was going on a cruise. And so he conveniently booked the same cruise so that he had a therapist on board on the cruise with him. Very smart man. Don't pick up on that. So my therapist winds up on this cruise with the patient because he was trached, and the wife was very eerie to take him on vacations, but felt very comfortable that our therapist was on board there. So she's got pictures of him. She came back with pictures of him everywhere, and you can see that he's actually slamming a hurricane there in the middle into his gastric tube. That we don't condone that, but if that's what makes you happy and that's quality of life for you, then hey, have at it. But you can see how mobility and getting out there, it's huge.
It might irritate it a little bit.
It might irritate, yeah, that's right.
Personal experience.
There it is. Someone just snitched themselves out.
Not advised.
Yeah.
So one more point to that from experience from one of our families. If you go direct, you don't need nearly as much.
That's right. True.
So there's
Very
of course
true.
Huge
Correct.
savings on Jonathan
Yes.
Jack. Instead of lining up 6 shots, about a half of a shot was more than sufficient.
It was.
So just be cautious of that. And if you're doing that kind of thing, it's great, but tell your medical team, make sure they know
Right, correct.
that stuff's going on. And
Yeah.
Enjoy, have fun.
Yeah, have fun.
But if you do the whole thing straight in like you used to, you're gonna be in trouble.
Right. Oh yeah, absolutely. So I had a patient who this is out in Texas, obviously, because you can see the guy there with his deer where he went hunting. And when I would go out and see this guy, he was just so disappointed at the fact that he wasn't going to get to hunt again. And when I went out to his house, he had mounts all over the house. I mean, this guy he was an avid hunter. He loved to hunt. And I said, well, why aren't you going to go hunt this year? He's like, he was on this machine like 18, 19 hours a day. He's like, there's no way I can't. But he still walked around a little bit. And I was like, you can do it. Take your ventilator with you. We give you some extra batteries. You got some extra batteries with you. And so later on that day, I get a picture from him with his gun hanging off of the blind and his non-invasive device on, and he's breathing right through it while he's hunting. And then later on, I get this picture here with him on the tailgate of the deer he killed. To him, that's quality of life. And if we couldn't give him that quality of life, he may not have wanted to fight as long as he did. That was his quality of life. Everybody has a different sense of what their quality of life is. We've had some patients that they want to see their daughters getting married in a year or year and a half. And they want to be there for that. And we tried to give them as much ammo as we can and prevent them from hospital admissions and everything so that the patient can get to experience that. It's another birthday.
So I have a question on the non-invasive devices. So for my husband was concerned when he first, we got the device, and he was having this upper respiratory infection, and we're trying to clear that up, and so that was kind of the challenge. He felt like it was shoving the secretions further into his lungs.
Correct. Yeah.
So is that, how do you deal with that? Because he can't really swallow the secretions, but once he's cleared up, he's doing much better with it.
Right. So two things happening. So you have an upper respiratory infection. We do need to get that cleared up and get him on antibiotics or whatever it takes to get that cleared up. But yeah, it can cause some of those secretions going down into the lungs and furthering the infection. So we just need to look at it and try to keep him from catching those respiratory infections and also keep his lungs as healthy as we can by giving him really good lung expansion. If it's not absolutely necessary at that time that he has that upper respiratory infection for him to be on the non-invasive device, then don't use it for that day or two.
So in that situation, you're better off.
You have to weigh your options and say, for example, we have COPD patients who it's kind of contraindicated to use a cough assist device because we can cause a pneumothorax. We can't cause their lungs to just completely collapse on them with that negative pressure because their lungs are very floppy. But I've sat there and seen these patients drowning in secretions. So then the physician will say, well, the benefits outweigh the risks. Do it. Either we let them drown in secretions or we do the cough assist. I may cause a pneumothorax, I may not. But at least we can try to get those secretions out. A lot of times, it doesn't cause a pneumothorax. It's very, very rare, but it can. So the benefits outweigh the risks, we do it. So if it's to the point to where your husband cannot breathe without his non-invasive device, but he has an upper respiratory infection, then you better use your non-invasive device. That's all there is to it. You're just going to have to use it and hope that the antibiotics kick in and take care of that. When he's clear, use it. Absolutely. If it's set up properly, right? Bulbar patients, it's a different setup. It is a different setup for bulbar patients.
And I don't know if they took that into account when they set it up. So that's
right. Yeah. Unless you've done some research on bulbar patients and how it truly affects the upper airway, it's probably not. So yeah, we need to titrate some settings.
Is not working
at all. Yeah,
so
I can see that. Yeah, I can see that.
Okay.
Yeah.
Go back.
Sorry.
No, it's all good. So next time you see this slide, you're going to see the beach.
That's right.
And
Yeah, that's right.
Parks and Recreation.
Now,
You're good in San Diego.
don't go surfing with the non-invasive device, please. The water will probably
I
damage
think
it.
you'll step up to that challenge. You're going to figure that out.
Yeah.
But we do have at most of the beaches here at the lifeguard stands manual beach wheelchairs. Just
Really?
those huge
Really?
towers. And many of the lifeguard stands have power beach wheelchairs. Now the power, they prefer you keep it on the sand and don't go into water,
Right.
at least not too deep.
Wow,
but the
that's
sand
awesome.
wheelchairs, people go into the surf a little bit.
It's good to hear.
The other thing we have on the bay is adaptive water sports. So they can do kayaking,
Wow.
or they have body surfing, different surfing solutions for people with disabilities that are phenomenal. People come from around into San Diego
That is
to
awesome.
enjoy those benefits. So when you see this again,
Yeah, it's
We'll
gonna be, it's
have
gonna look totally different. Yeah.
some ocean views included.
Yeah, we
out
do.
there, so.
What is your, what is your advice on getting in the water in the ocean with the G-tube? Do you have to seal it?
Ooh, that would
or-
be. It's a great question. God, that's the first time I've been asked that, so I will find out. Yeah,
And
definitely.
definitely talk to your medical
Dietitian.
team.
Yeah.
But the sales pitch given today is that you can go in the sauna, you can go in the bath, you can go in water. So I mean, that's what they say. They
So.
want you to enjoy. It's not a showstopper.
Right.
If you get one early, you're not using it yet. Oh, I just cut myself from going into the water. They had told us, no, that's not true. You can.
Good to hear. Yeah.
Yeah.
It's a great question.
Yeah.
So we have a little video, and I don't know if we can actually get that to play.
Yep.
There are some patients and family members and even healthcare teams that always ask us why we do what we do, and this is why. Can you guys see that? So that's basically that's the reason why we do what we do. This patient, it just so happened that he was in San Antonio traveling from another part of the state. See if we can get the mouse to work.
In the middle of it, just hit pause. It won't let you.
And then the mouse won't.
Okay.
There you go. I think we lost the last slide, but that's okay. I just had my contact information on there. But this patient was traveling with his respiratory equipment, and it malfunctioned on him, so he ended up in the emergency room. And when he got in the emergency room, he's in another city. No one would help him. They're like, well, your ventilator, it's shot, so there's nothing we can do. So he was stuck in the emergency room. The emergency room notified the ALS Association somehow. ALS Association notified us, and we went out there and just took him a ventilator. We didn't ask any questions. We just showed up. We said, here. The moment we handed it to him, he wheeled right out and went straight to the graduation so that he can make it to this graduation. So it's rewarding for us to see that. This made nationwide news. It was on CBS in the morning with all the morning shows. They all made it. Because it was very touching. So that's why we do what we do. So when people ask, why do you do what we
Everybody
do?
should care that much, though.
You should. But they had made probably 5 or 6 other calls that morning, and everyone said, well, it's not our patient. There's nothing I can do. And I get to some extent a little bit of that because, we have to have orders and stuff like that. But it was as easy as, just give me an order. Let's just get him taken care of, and let's get him down there right away. Later on the next day, we're in San Antonio. El Paso's probably, 10-hour drive, 8-hour drive, 9-hour drive. And our ventilator ends up in El Paso because now how does he get to El Paso? So I said, well, go ahead and take the ventilator to El Paso, and we'll worry about it later. They gave us all their contact information, and then we just waited. Probably a couple weeks later, they end up on service with us, and we started servicing the patient from then on out. So notice what comes out of doing the right thing. They wind up on service with us, and it just turned out to be a really great experience. But so anyway, my contact information's up there in case anyone needs to get a hold of me or whatever. You can also look at our website, rqsbreathe.com, and you can see all the stuff that we do. My email address is on there. If you have any questions, you can obviously email me, text me, whatever. It doesn't matter what it takes. Just get a hold of me, and I'll be glad to help however I can. That's about it, unless you guys have any other questions.
Thank you very much.
Yeah, you're very welcome. Very
Appreciate it.
welcome.
So just a couple of things at the end. You've been introduced to a lot of information today, which is always beneficial. Please share and ask with your medical team.
Right.
Keep them involved in things you're thinking, things you want to try, questions you have. The whole G2 thing, there's a GI consult that your team can refer you to. Go talk to the people who do it. Get the information straight from them. Talk to the peers in support group meetings and so forth. The voice banking is a good example.
Yeah.
We've got people who say, use me as a case study. I didn't listen, I didn't do it. Now I can't. There's so many things you're dealing with at the beginning. Some of the stuff you don't understand. But that's their message. The trach, the whole question of the trach. Yeah, United States, percentage of people who choose that option is pretty low. In other countries,
That's very
Japan,
high.
for example,
Yeah, it's very high.
50% have a trach. So it's just a different way of looking at it. We have 3 videos we provide that help people understand. Again, talk to your medical team. It may not be the right solution for everybody. For some people, it's an excellent option. It just depends on their orientation, what their goals are. And these are things that are helpful to talk about earlier rather than later. And then once you make those decisions and you do your advanced directives, please share with your family. Don't have siblings or children finding out in the hospital that information. It's always better to share it ahead of time.
One of the interesting things that I think with that advanced directive with ALS patients, it's really interesting because actually our son is a hospital, so he works in a hospital. My husband actually is a retired head neck surgeon too. So when he did the trachs, he doesn't want to do a trach. So he knows what's out there. So the whole thing. But one of the interesting things, my son being in a hospital, he's like, with your advanced directive, you might be a DNR, but if you have DNR, but there could be extenuating circumstances.
Absolutely.
So if you're in there because of an ALS issue that is correctable, and you say I'm DNR,
Right.
now if I'm having a heart attack and I'm already dead, don't revive me. But if I'm
Right. It does not mean do not treat.
right,
And it
but
does not
there's-
mean do not intubate either.
But a lot of hospitals and
Correct.
ERs will do that. So
Absolutely.
you have to be very, very specific.
Correct.
In that to say, I mean, he had it written up to say, this is what it is, and he texted and said, this is exactly what you want to say when you go in there. So it's not that even to say you have your advanced
Correct.
directive, you need to be specific, and a lot of times the patients don't understand
Correct.
the difference. You say, we're DNR, but now you're struggling, you know,
To
I don't
breathe.
want to suffocate to death.
Correct. Yeah. DNR does not stand for do not intubate and do not resuscitate, or it stands for do not resuscitate. Doesn't mean do not intubate. Does not mean do not treat. So there's all of that stuff that it's funny how I've gone into many hospitals, many emergency rooms, and I'll ask the same question to the physicians and to this hospital staff, and I get a different answer everywhere I go. A different answer everywhere I go, and I was like, whoa, wow, this is crazy. No, if it's DNR, it's DNR. And I go, no, it's not do not treat. If I'm coming in here with an MI, with a heart attack, I go, can you give me medications to overcome that? Yes. Can you change my rhythm by shocking me out of my rhythm and putting me into a normal sinus rhythm and making me live 10 years longer? Please do. Yeah. Don't not do that. So yes, what you're saying, yes, you would want to look at your advanced directives and be very specific as much as you can.
Yeah. And the other side of the coin happens. You can have very clear advanced directives and call 911, end up in emergency, and get a trach
Right.
that you never wanted. But then the Monday morning quarterback says, well, why'd you call us? Why did you come here? So now you're here. We're gonna put this trach in.
Right.
You know, so it is an area of sensitivity. You're right. You have to be extremely careful how it's worded. As professionals, talk to your social worker and your medical teams. If your medical team doesn't include a social worker or somebody that, you know, there's other resources out there. Compassionate Care for California and other organizations. Talk to us. We'll get you connected. And then have it available. When the paramedics come, you know, have that little sticker on the door jamb. Hey, look on the refrigerator. The Vital Life is there. Advanced directives are there. If you're traveling,
Right.
have it with you.
Correct.
We love the placards.
Yeah.
So,
Yeah, we need one of those.
Yeah.
yeah.
Yeah, I'll be giving a bunch to
He's
Steve
gonna have the whole
and
second.
Keith. Yeah.
So on these issues, to our listening audience and those that are here, communicate to your medical team. Tell them what you're thinking. When you go in for your appointment, especially like a clinic situation, where you're going to see 9 professionals in 3 hours, have somebody there who's got the questions ahead of time, and feel free to send those in before you show up. And then somebody who's not so terribly emotionally involved, an extra person, a sister-in-law, a son, you know, whoever, who makes sure all the questions get answered. Because when you're in an environment, you're talking with the neurologist or any of the specialists, you can get off track on some very important things. But on the way home, you don't want to have that feeling, oh, we never asked about this. Right. So the more you can do in advance, give them the questions and have somebody there to help get them all answered, just makes them more productive. Sure, go ahead.
You know, I think one of the big things is to have a team where you have a social worker or a case manager, which a lot of times you don't have that because you have to have a contact point. Like,
Correct.
you know, if you have a direct point of contact, it makes things a lot easier, but a lot of times you don't have that and you have to fight to end up getting that. So it is a difficult finding the right team, and even if you think you have a team and you call them 3 days later, you hear back.
Correct.
Yeah.
When you're in crisis mode, 3 days is a long
long
wait.
time. It's too long.
Yeah.
Yeah. So, you know, again, if you're waiting for something, it's time sensitive. We're 24/7. Text us, call us, tell us what's going on. We typically should have a back door to get somebody to respond quicker. You know, some of the clinics people interface with, they're 80% research, or they're medical school. They don't have office hours 5 days a week. They might be the best resource for what we're trying to do, but they're not there for us Monday, Tuesday,
24/7,
Wednesday,
right.
Thursday, Friday, certainly not Saturday, Sunday. So use us. We'll try and help you as much as we can
Sure.
to get connected with somebody who's going to give a response. But you're right. As patients, and we'll do this on your behalf as well, you need a point of contact. You need to understand how communication flows, how they use their systems. In other words, if you go into the Follow My Health and send a message, what's their standard? How often do they even look for messages in there? It's not intended for something where you need to answer back fast. But some people think, oh, this is my inside track.
Correct.
No, it's a secure, encrypted. It's not immediate response track.
If you miss their return call,
Uh-oh,
Oh,
you're in
yeah.
trouble.
Then you're
Yeah.
back to zero.
You're 3 more days.
Yeah. So save the date. On a different note, May 8th, we're all going on the USS Midway. So if you're not aware of that, contact the chapter. You should be getting postcards. We have our normal third Saturday support group meeting at Ability Center here a week from Saturday. That is Easter weekend, so we'll probably
Cool.
have some folks skip it and other folks will come. It's totally fine. Do what works for your schedule, but we will be there. And that's more of a peer-to-peer opportunity for our
Absolutely.
families. And we'll have those placards.
Absolutely. Yeah, we have
care
lanyards by
services
then.
meetings for like caregivers or
The care services meetings are these. These are the informational presentations. The support group meetings, we take the caregivers, spend a portion of time alone in their own room, and the people with ALS have their own round table.
Nice.
do you find that really helpful for
The,
people?
the, the families do. Yeah, we follow what their preferences are. We used to have facilitators for those meetings. They didn't want facilitators. So right now, this is what they want and what's working for them. And they want to talk to each other without their spouse or loved one in the room.
Right.
So we provide that opportunity. And it's volunteer. You know, if you want to get up and leave, you do. If you don't, you stay together. It's totally fine. Okay. So that concludes our webcast. Thank you so much for joining us. And for our audience here, it'll be a little bit before the microphone shut down, so we'll try to
Careful
be
what
a
you
little bit
say.
soft voiced.
Thank you. That's what I do. I haven't gone into your office, and I think we'd like to, because we'd like to look at wheelchairs. My husband, like as I said, has bulbar ALS, so he's still getting around, but he is getting very weak. And it is interesting with all this stuff that you start seeing happening as now that he's on 100% tube feeding, and I'm control, right? And I make sure he's getting the proper calories and hydration and monitoring everything. He's actually improving, and his respiratory function is also improving. I don't know if it's the hydration or just calorie intake or all of the above. But he's like literally like 3 weeks ago maybe thought he was dying. And now he's up and walking and actually getting around. So
He was driving his car yesterday.
he was driving the race. So, you know, it really helps, but to find somebody like you, like, that's kind of where we are. We have all this equipment, and I'm like, and now what do you do?
Well, your story is actually better than some I've heard. Sometimes it's like the UPS guy.
It is.
Drops off the equipment
Yep.
in the box and leaves.
Yeah, they'll tell you to YouTube it. YouTube coffees how to use it.
Oh, that's just.
And how to change the settings and
Yeah,
stuff?
but that's annoying that you can't do that. Like
Yeah.
that's very dangerous. Changing the settings. I mean,
Yeah,
patient
but
has
patient,
that
you know,
reaction.
But what you do with equipment today is all Wi-Fi.
Right.
So these people, equipment providers, the pulmonologists, the respiratory therapists you're working with have access to your data.
So,
And they can literally change the settings remotely on some of the equipment.
but
From their
how,
office.
that's the problem, is we don't really have a respiratory therapist, so,
Who's your provider? Apnea?
yeah.
Yeah. I mean, from what you were describing, I almost knew who it was.
Yeah.
But
So
that
they
can be
came in,
fixed.
set it up, right, and that is the issue, because literally came in, go to the emergency room, he was put on a BiPAP and was kind of, things are progressing, and then they're progressing very quickly. And it was like, you know, you're kind of this, excuse me, but oh shit.
Yeah.
So we get back, we go to the emergency room, the BiPAP helped, so I'm on the phone trying to get everything here. So I got, pretty quickly, I got, you know, the non-invasive device, I got the, you know, cough assist, and they came and they brought all that up and set it up, and they're like, okay, I see ya, like you say.
Right.
And now we're like, okay, the cough assist wasn't working at all. He has this upper respiratory thing. He's struggling to breathe. He's like, you know, and I'm going like, panic, because it's scary watching him breathing. And I'm like, usually sleep with earplugs, and I'm like trying to listen to see if he's still breathing all night. And
So you're not getting rest.
no, it's scary. I'm like, I don't want to watch him suffocate. And then and then I can't get the food to work, and the bag's not working, the pump's not working. You know,
All the stuff that
everything
nobody
was
warned you about.
crashing at one time. And so,
What most